I think we'll go ahead and get started with our first speaker, which is Dr. Sarah Sanghavi, and then we'll take a short break and then we'll move forward with our visiting professor. So without further ado.
Thank you. All right, good morning, everyone. I think everyone can hear me. So it's fun to be here in person as the opening act for Dr. Malapati, who made his way in from coffee. Today, we're going to be talking about prolonging circuit life in CRRT. And over the last few years, I've learned that there's just a lot of variability between how we run CRRT, both across the US, even within our own hospitals, within our institution. And it's largely because of differences in models of care, nursing coverage, equipment availability. But I think there's a lot to learn in exploring why institutions have different models, why they've adopted them, and revisiting some of these early papers in how we describe and use CRRT. So my disclosure, I serve on an advisory board for Fresenius, which owns Next Stage. All right, so we'll talk with why it matters. And there's a lot of consequences to CRRT interruptions, a lot that affect patients. So blood loss, inconsistent medication clearance. We don't know that the antibiotics we're prescribing is actually the antibiotic that they're getting. There's an increased risk of infection and errors every time we have to stop the system, put a new system up, increased interaction with the blood, which can increase the risk of bacteremia. You have lower delivered clearance. We know we have these targets for clearance. We might have specific things we want to remove, like potassium. And if that machine keeps alarming and keeps stopping, we're not actually removing these substances. Costs are higher due to new filters, and then a lot of increased nursing time and it's a nursing workload and mental load. So the question really becomes, how do we maximize circuit life without increasing patient risk, nursing time, and cost? And this is a question that doesn't really have one answer, but we're going to talk about a few possible solutions, such as improving vascular access, improving blood flow and modality, or looking into whether that actually improves outcomes. And then lastly, anticoagulation. So this is the OG RCT in CRRT, the ATN trial, which was a US trial looking at different prescriptions, either conventional and intensive. But what I want to point out is just how many times the word prescribed by primary treating team show up. You can see it shows up in blood flow rate, dialysate composition, replacement fluid composition, ultrafiltration, anticoagulation. And this is just to point out that there really isn't a single best practice, but rather a best fit for specific institutions. These are 4 more contemporary trials of CRRT, all RCTs. And you can see that in each of them, we're using different modalities, either CVVH, CVVHDF. You can see that when it comes to anticoagulation, the citrate can be tied to the blood flow. It might be tied to the arterial calcium. It might be tied to the post-filter calcium. And when we look at heparin, same thing. It may be given to maintain an APTT within a range. It may be a fixed rate, and they might even use protamine. So lots of variation, not really a standard here. So let's start with vascular access, which I think is an overlooked part of circuit failure. And it really accounts for up to 30% of circuit failure. When you have pressure alarms that go off, that stops the blood flow. It results in turbulent blood flow when you don't have access that functions well. And generally, the early catheter dysfunction is going to be due to poor positioning. And we all know from the Cathedia trial that right IJ is the preferred site. But I think we don't spend enough time talking about or educating others about the depth of right IJ catheter insertion. And so it really should be the patient's height in centimeters divided by 10. That's been validated in this study, actually looking at this. And if I take my height, which is 5'4", 5'5" on a good day, or if it's my driver's license, and convert that to centimeters, that's about 162 centimeters. Meaning that I should have a 16 centimeter right IJ catheter if you're starting me on dialysis. That would not be the same for, and I'm just looking at tall people, and I see Carrie all alone there in the back. That would not be the right depth of catheter for him. So if you are at all involved in purchasing for your institution, having a bunch of 16 centimeter trialysis lines is probably not going to be useful for the majority of people. Late catheter dysfunction is generally due to obstruction, whether that's extrinsic or intrinsic. And extrinsic dysfunction is kinking, but another reason this happens is if you have inadequate tract dilation. So these are polyurethane catheters. They're rigid on insertion, but when they warm up to body temperature, they soften. And so if people dilate using a single dilator without using a sequential dilation after that, then the soft tissue around it can kink the catheter extrinsically. And this happens often. And I think because oftentimes nephrologists are not involved in the insertion anymore, we see this problem definitely when people turn their heads and the tract hasn't been adequately dilated. And then intrinsic is this just thrombus within the lumen. So if you're trying to assess the vascular access, trying to troubleshoot it because the CRRT isn't working and the patient's potassium is rising, things you can do are aspirate 20 mils in 2 seconds. If you can do that, then your catheter is supporting blood flow. And this study was actually done looking at supporting blood flow rates for hemodialysis. And we generally don't need 300 mils per minute for CRRT. Nevertheless, if you can aspirate 20 mils in 2 seconds, you know you're going to be fine. And then if your arterial access pressures are more positive, meaning lower numbers than negative 100, likely you're going to encounter some catheter dysfunction and maybe a shorter circuit life. Okay, so these are pictures from the last couple of months. This is a chest x-ray with a patient who has a dialysis catheter. The blue arrow depicts the carina, so where the trachea branches into the main bronchi, and the orange arrow is a catheter tip. And so this patient had a catheter at 15 centimeters of depth. They were 68 inches in height, and you can see that that tip is landing higher than the carina. And just so we know that the caval atrial junction, which is what we're trying to get to, is about 2 vertebral spaces below the carina. So more like right here. So you can see this catheter is in the high to mid SVC where it's not going to get the flows we need. This is a catheter I placed on a different patient. I did it at 19 centimeters depth for a 71-inch height person. And so, this should be an 18 centimeter catheter. I always go a little deeper because I can pull out if I need to, but I can't place it further in if I have to, because at that point, the catheter is not sterile. Here you can see the carina. Here you can see that the catheter tip is down here, 2 vertebral bodies below the carina at the cavo-atrial junction. So this, it wasn't hard to find a lot of pictures like this. To find this picture, I just had to find the one I put in myself. And so this is a problem that I think is happening more and more frequently. And after I made this slide, I sent a nice email to the person who put this one in, just to remind people, because I don't think this is something we think about that often. Okay, so now we're going to switch to modalities. Is one modality better than another in preserving circuit life? So this was actually a very recent trial done at the University of Iowa. It was a pragmatic trial. They alternated the modality, either CVVH or CVVHD, in 2-week blocks. That's because their fellows rotated on the ICU service in 2-week blocks. So it made it easier for them. Either everyone was on CVVH or everyone was on CVVHD. There's a total of 161 treatments. Everything else was standardized. The blood flow rate was 150 and regional citrate anticoagulation was used. And they found that the median filter life was longer with CVVHD. The mean filter life also longer. And the number of filters that are lasting more than 72 hours was almost double when they used CVVHD. And this builds on a lot of older observational data that suggests the same. Because if you're not moving large amounts of fluid from the blood compartment to the effluent via convection, you're not hemoconcentrating across the filter, you're less likely to clot. And that brings us to filtration fraction, which is this idea that you are less likely to clot if you have higher blood flows and you're not hemoconcentrating across the filter. And so older studies showed that a post-filter hematocrit of about 45% is associated with filter clotting in CAVH. And I said it was older studies because that was when we were using arterial venous hemofiltration. And so instead of actually measuring the hematocrit across the filter, instead we're looking at the surrogate marker, which is filtration fraction. But it's actually never been evidence-based. And so here's just an example math problem of what could happen here. So your filtration fraction is your ultrafiltration rate divided by your plasma flow rate, which is just your blood flow rate times 1 minus the hematocrit. And so if I have a patient who is getting 2,000 mils per hour of replacement fluid, and this is post-filter, then that is 35 in mils per minute divided by 150 times 0.7, assuming a hematocrit of 30, you get a filtration fraction of 33. We would say that's too high by the current recommendations. Now, if I instead change that to a pre-filter replacement fluid, again, still using convection, then that ultrafiltration rate is still 35, but because I'm putting in the fluid prior to the filter, then the blood flow or the plasma flow is diluted by that pre-filter fluid, and this actually becomes 150 times 0.7 plus the 35 pre-filter, and now my filtration fraction is 25%. That makes sense. We can all agree that putting fluid before the filter, increasing the amount of plasma flow is going to decrease hemoconcentration across the filter. But what if I increase the fluid replacement rate to 50 mils per minute? So now the numerator becomes 50. I add 50 to the denominator. So the numerator is increasing by a greater percentage than the denominator. And somehow my filtration fraction is poor again. But I'm not actually increasing hemoconcentration across the filter, which is the real issue. And so filtration fraction is nice to illustrate this point that post-filter replacement is, that pre-filter replacement is superior to post-filter replacement. But beyond that, it doesn't have a whole lot of use. And so we often chase this blood flow rate. If I increase the blood flow rate and make it higher, then my filtration fraction should go down. I should have less clotting. We have no data to suggest this actually works as long as you're in a narrow range of blood flow rates. So there are 2 small RCTs that have been done so far. The first one was 34 patients on CVV-HD, comparing a blood flow rate of 125 to 200 to 250. The other, and showed no differences, but again, very, very small study. The next one was 100 patients on CVVH or CVVHDF. They compared a blood flow rate of 150 to 250. Everyone was on heparin. And when they used CVVH, they used 2,000 mils of dialysate, replacement fluid, 50% pre-filter, 50% post-filter. For CVVHDF, 50% dialysis, 50% post-filter. And they found no difference in the lower blood flow rates or the higher blood flow rates in terms of clotting or circuit life. And the thought is that maybe at blood flow rates greater than 250, you're actually getting some turbulence at these resistance points, and therefore it may not actually be helpful, knowing that this filtration fraction concept really doesn't necessarily apply. And that at blood flow rates less than 80, you actually do have sluggish flow and sticking to surfaces, so that's probably the lower limit of what's acceptable. Okay, moving on to CRRT. Does everyone need anticoagulation to preserve circuit life? Maybe not. So this was, again, an older study, but it's how many institutions practice now due to safety concerns. So if patients had an INR greater than 2.5, a PTT greater than 60 seconds, platelet counts that were less than 60, or were 24 hours post-surgery, they did not receive anticoagulation per this institution's protocol. And so then they retrospectively assessed 300 circuits. And again, 47% of them received no anticoagulation per their protocol. The other 126 received either 5 to 10 units of heparin per kilogram per hour. And they all received CVVH at standard blood flows and replacement fluid rates. And you can see that 31 of these 174 circuits without anticoagulation just didn't work. The circuit life was less than 6 hours, and they tried again, and it was still less than 6 hours. So those patients were actually converted to regional anticoagulation, which at that time was heparin and protamine. But in the people who didn't fail early, there was no difference in circuit life between the remaining. So about 90 hours versus 20 hours back in 2004. And so there are probably a subset of patients who are going to need anticoagulation, even if they're at high bleeding risk. But about 80% of them may get away without anything, specifically if they have thrombocytopenia, which has been shown time and time again in multiple different studies. The other people who may be able to get rid of or get away without anticoagulation are people who are on prolonged intermittent renal replacement therapy. So this was a study out of Rush University. They looked at 100 patients receiving 457 treatments, and they were doing PERT, so 9-hour treatments with very high effluent rates, high blood flow rates as well. And they found that filter clotting only happened to 3.3% of patients. So if you're only looking for a circuit life of 9 hours, you likely don't need anticoagulation. We tend to use more continuous, longer therapies at our institutions, however. Okay, so let's talk about unfractionated heparin. So kinetics are variable and unpredictable. At therapeutic doses, heparin is metabolized by cellular uptake in the liver, which is saturable with zero order kinetics, meaning that heparin should be cleared at a steady rate. It doesn't undergo enzymatic degradation in the bloodstream, but it's highly protein bound, so it's not dialyzable. And our APTT assays vary widely. So in some places, you'll see APTT targets. Other protocols will say 2 times normal, 1.5 times normal, and there's a lot of variability here. And again, a very old study, but a very old study that informs our practice. In patients receiving CAVHD or HDF, they saw that the risk of hemorrhage increased. Oh, I'm just going to stand still and maybe I'll come back. Yay, okay. The risk of hemorrhage increased by 50% with every 10-second increase in APTT. That was when people were getting arterial cannulas, so hopefully not the same risk anymore. But the risk of coagulation decreased by 25% with every 10-second increase in APTT. So it really is a trade-off. Interestingly, filter coagulation or hemorrhage was not correlated to the dose of heparin. So even though a lot of protocols use dose of heparin, whether that's 5 units or 10 units per kilogram, the coagulation hemorrhage was correlated to APTT, so the effect of the heparin, but not the dose, just underscoring the variability in heparin kinetics. This is a protocol that you do not need to look at in detail. I put the main points up here at the top, which is start heparin dose based on a bleeding risk. If your APPT is too high, reduce the dose. And then if your circuit's not lasting, increase the dose. And really it's a balance between how can I make my circuit last without causing harm to the patient and increasing their bleeding risk. Doesn't matter if heparin is infused pre-filter or intravenously. So one of my ICU colleagues asked me this because there was a patient who was systemically anticoagulated. He said, anecdotally, I just don't feel like it's doing as well as the pre-filter heparin. And so there's one study I found, single center, 84 patients, where their target APTT was 60 to 70. Again, lots of variability from what you've seen so far. And the first thing, and they sampled APTTs from the central venous catheter and directly post-filter. The first thing you notice here is that for a target of 60 to 70, these dots are all over the place. So clearly we're not getting that target. Secondly, you'll notice that the post-filter APTTs are much higher than the APTTs from the central venous line. Third thing you might notice is just the spelling of scatter, which is fine, but noticeable. And so, patients who are systemically anticoagulated may not actually reach the same post-filter anticoagulation, depending on what their PTT goal is. And pre-filter heparin is actually likely superior. All right, I'm running low on time here. So here is just a really beautiful illustration of regional citrate anticoagulation to go over first to set the stage for the next few slides. So with citrate anticoagulation, you're anticoagulating the circuit, not the patient. At least that's the goal. And so citrate is infused pre-blood flow pump, and usually a zero calcium dialysate or zero calcium replacement fluid is then used. The citrate will chelate the calcium, which is a cofactor for the vitamin K binding factors, vitamin K clotting factors and common pathway clotting factors. And so in doing so, you reduce the ionized calcium to about your goal, which is 0.3 to 0.5, but that varies as well. And that anticoagulates this entire circuit. About 50% of the calcium citrate complexes are removed in the effluent because these are dialysable. And so coming back to the patient, they now don't have calcium or don't have 50% of the calcium they used to. And so calcium infusion is added here. So in 2020, a large study was done in Germany of 600 patients comparing pre-filter citrate targeting an ionized calcium of 0.25 to 0.35 and intravenous, so not pre-filter, but intravenous heparin with a target APTT of 45 to 60 seconds. And what they found was that there was significantly decreased major bleeding from 16.9% in the heparin group to 5.1% in the citrate group. No difference in RBC transfusions, and interestingly, a slightly higher infection rate. In a post-hoc analysis of this study, they did not find any difference in incidence of bacteremia between these two groups. And colonization and infection weren't really determined. So that's the first time this has popped up, and not clear if this is really due to citrate or some other mechanism or just by chance. There's a study looking at the ionized target for anticoagulation because this 0.4 cutoff was based on in vitro studies of healthy people where they took their blood, put citrate in them, and then look at thromboelastography to see when it clotted. This group decided to say, why don't we see what would happen if we just change our practice from an ionized calcium of 0.25 to 0.35 post-filter to 0.3 to 0.4. So they made this change in a before and after study and saw no difference in filter life. So potentially we don't need to be as strict with our ionized calcium goals. What about using calcium-containing solutions? This is from UCSD when in 2017 they had shortages of calcium gluconate. So decided, is there another way that we can prevent ionized calcium from getting so low that they need such high doses of calcium gluconate? And so this is really the key piece here, where some patients received different replacement fluids, whether that was lactated ringers, bicarbonate, or calcium-containing dialysate or replacement fluid. And they found that they reduced calcium gluconate requirements by 30% and actually increased calcium delivery to the patient, but they didn't study filter life. Luckily, we have a newer study that did look at filter life, although very small. So this was an RCT in China of 64 patients who all receiving CVV-HDF with 3 milliequivalents per liter of calcium compared to 0, used the same target that we use in most of our studies. And they used a calcium infusion PRN for the calcium-containing solution group versus a steady infusion for those who did not. Steady infusion for those who did not receive calcium-containing fluids. They found no difference in circuit life, 58 hours versus 55 hours. So potentially, calcium-containing solutions can be used. It may decrease nursing workload. Again, all of the things we're doing here are to decrease patient harm and decrease nursing workload and cost. Okay, I'm close to time, but I briefly want to talk about metabolic alkalosis because our fellows tell us that this is a problem often that they see in patients who are receiving citrate. And it depends on the amount of citrate we're giving. If we're using calcium solutions, we probably need to use more citrate, meaning more citrate is going to reach the patient and be metabolized to bicarbonate. If we have a lower ionized calcium goal, we'll be using more citrate. and then also increase the risk of metabolic alkalosis. Because of this, there are so many different solutions available, many of them that have lower bicarbonate concentrations, and those lower bicarbonate concentrations tend to be in the solutions that are zero calcium, meaning solutions made for citrate. So that is the way around the metabolic alkalosis. All right, we're going to skip over the absent citrate protocol, but it's really cool, and you guys can read about it in Kidney 360. And just sum up by saying that the goal in prolonging circuit life is to really maximize this benefit risk ratio to the patient without significantly increasing nursing time, errors, and cost. A lot of this is going to depend on patient characteristics, nursing training, protocols that are in place, volume that you're doing at your center, and then the availability of the equipment and supplies that you need. Some benchmarks that have been proposed are greater than 50% of circuits with a lifespan greater than 72 hours. That's in adults. In children, a proposal has been greater than 60% of circuits with a lifespan greater than 60 hours. Thinking about how teeny those little vessels are and those little catheters are, that still seems like a pretty lofty goal. So in summary, vascular access, I'm going to stay still again. There we go. Vascular access, site, and depth of catheter affect circuit life, and we should probably be taking a more active involvement in vascular access if our ICU colleagues are placing those lines. Patients with thrombocytopenia may not need anticoagulation. CVVHD may improve circuit life compared with CVVH or HDF. It'll come back in a second, I think. Is the power out?
Well, you need to plug in a power cord.
Oh, okay. All right, I'll just talk. Oh, I like my last slide too. Can we plug it in? I want to make this last slide happen, but I'll talk.
Do you have a power cord? You have one.
Do I have a power cord?
I have a power cord too.
My computer's not dying.
No, but I think just for whatever reason it cuts off when it's not plugged in the power.
No, so nothing.
You don't have it with you?
No. We're good. Okay. So blood flow rates of 250 have not been shown to be superior to 150 if you're using post-filter fluids and anticoagulation. Regional citrate anticoagulation, yay! All right, decreases the risk of bleeding. That was just a pop out, pop in, and increases the filter life. Can be used with calcium-containing solutions, which may be safer, although may result in a bit of a metabolic alkalosis. And really, overall, program should find the right fit. This was the last slide I wanted. So this is my thank you slide. This was my November. If you guys aren't in the pictures, then I need to see you more so we can take pictures. I think we might have time for a couple questions.
Years ago, the argument for CVVH was that it cleared more middle molecules from inflammation. And then there were studies and expert opinion saying they really only reduce those middle molecules to a small extent, and it's not clinically relevant. And then internationally, now we've seen not the CRRT, but hemodiafiltration with reduced mortality, and again, the argument about middle molecules. So my question is, what's the current state of that argument for CRRT? And the related question is there any reason to, given the data you showed about better filter life with CVVHD, is there any real reason to choose CVVH or CVVHDF over CVVHD?
Yeah, and I'll just restate the question on the mic. But basically, is there any benefit to middle molecular weight molecule clearance with convection therapies as opposed to effusive therapies? Bringing up the recent CONVINCE trial in hemodiafiltration. And so what's interesting is that, yes, we've done the studies to look at middle molecule clearance. We removed them. Is there actual mortality benefits that we're seeing between modalities? And the answer is no. Why are we seeing it hemodialysis and not in CRRT? I think the CONVINCE trial wasn't convincing enough for me personally for that reason. And what was interesting in CONVINCE, it was actually a lower infection rate that probably was a primary driver of the decreased mortality, not these, the cytokine milieu, which was proposed. So I at the VA, we use CVVHD. We do not use a convective therapy. I don't think there's strong data to suggest that we need to. I would say almost many institutions across the US do use a convective therapy, but there are plenty, University of Chicago is one, that only uses CVVHD as well. So I don't think that there is a strong reason to choose convection over diffusion. That being said, there are still a lot of new studies coming out, specifically looking at absorptive techniques and absorptive filters, trying again to target these middle molecular weight molecules. And maybe then we'll see some benefit, and that might change our current thinking. Leah?
Just two related questions. Are there any specific filters that seem to be less thrombogenic? And our head nurse at CRRT at Harborview is very fond of making this distinction between filter clogging from plasma protein versus clotting, and that the reaction to those should be different, and that we can somehow tell the difference between those very
Yeah. So the first question, this is from older data. I think the filters now that we're using are all pretty similar, but these, and I hope I'm saying all of these right, there's polysulfamide filters and acryl nitrite filters. And it seems that the acryl nitrite filters have more clotting. So that would be one difference in filters. And then in terms of the question about clogging versus clotting, so clogging is going to reduce the efficiency. So that what you're prescribing on CRRT may not actually, you think you're prescribing a 2000 effluent, and that's not what's actually happening if you actually measure the effluent urea nitrogen compared to the blood urea nitrogen. University of San Diego does that on all their treatments every 12 hours. And so clogging is going to change that effect, but you're going to maintain circuit life. Clotting is going to be a big clot, everything stops, and you need a new circuit. Some would say that you can look at the transmembrane pressure, and if it changes acutely and suddenly, that's a clotting issue. And if you're seeing that it's slowly decreasing, that's probably a clogging issue. And then it just depends on, right. And then does it actually change how long your filter is in use? Is this slow clog eventually leads a clot? And I can't say that I have data on that to prove one way or another. I can tell you it reduces the efficiency. Yeah, Megan.
I think I went to this in fellowship, but I can't quite remember. Do you have any way of looking at obviously we don't add, but
right. So there are bunches of different ways to anticoagulate a circuit. So not systemic bivalve, but using bivalve in people who have HIT or even dalteparin, fondaparinux, different types. I did not dive deep into them because they're small. We use this at our center, but we don't have head-to-head comparisons. A great question. Okay, I'm at time. Thank you.